Very important topic, osteoporosis, we are going to cover. Might take more than one lecture. Let us see how far we can go today. It is a hidden hazard. Many a time you don't suspect. Many orthopedicians I know, they treat fracture, but never identify the osteoporosis. Somebody comes with fracture, 60-year-old woman. They nicely treat the fracture, do everything possible, but do not prevent future fracture by not investigating for osteoporosis. Happens 9 out of 10 times in the hands of orthopedicians. Means lack of awareness. Okay, it's a preventable disease. Look here, these are the various international references from. We have got National for Orthopedic Foundation, Bone Health Update, Chef AC UK, and then so many references we have got. And the radiographs are from that last website, radiography debris at ac.uk. So objectives of this CME class is to understand vitamin D, calcium, and bone metabolism. Most of you are not very familiar. You know vitamin D is important for bone, calcium is important for them. That's all you know. Beyond that, you do not know how they actually do the process. Identify and screen the individuals at high risk of osteoporosis. Who is at high risk of osteoporosis? We must understand. Recognize the risk factors that call for osteoporosis. Screening, assess patients' diet that affects bone health, advise diet and exercise to ensure bone health. Be familiar with current treatment of osteoporosis and osteopenia. Actively look for the diseases leading to osteoporosis and fractures. Okay. Vitamin D, the sunlight hormone, the sunlight. So the sunlight impinges on the skin and then converts a substance called 7-dehydroxycholesterol into cholecalciferol. 7-dehydroxycholesterol is a central molecule for all androgen synthesis, estrogen synthesis, steroid synthesis, vitamin D synthesis. Everything that is manufactured in the sterol ring is from 7-dehydroxycholesterol. 7-dehydroxycholesterol, by the action of sunlight, is converted into an active form called an inactive form called the cholecalciferol or vitamin D3. Vitamin D3 is not active by itself. So it has to also come from dietary intake of vitamin D3 and also supplemental vitamin D2 if you give in the form of capsules. You can give fish, meat, milk or rich sources of vitamin D3. Then what will happen? This 7-dehydroxycholesterol, after becoming the cholecalciferol, requires 2 oxidations. 2 signatures have to be put on the check for it to be encashed as vitamin D2. Signature 1 happens in the liver, that is 25 hydroxylation. At the 25th position, a hydroxyl group is added by the liver. That is the first signature, that is 25 hydroxy cholecalciferol. It is still not active. And that's also called the calcitrol. And then the second hydroxylation occurs at first position in the kidney, that is 125 dihydroxy cholecalciferol, also called calcitrol, which is the active vitamin. See how important it is to understand. The skin integrity should be there, exposure to sunlight should be there, dietary intake is important, first hydroxylation, liver function should be good, kidney function should be good. Then only the final product of vitamin D3 active metabolite is produced. Vitamin D, which is 125 dihydroxy cholecalciferol. Okay. Now, coming to the calcium metabolism. 1000 milligrams is generally taken in through the GI tract, out of which 900 milligrams goes through. Only 100 milligrams is available for absorption. Okay. Extracellular fluid contains 1300 milligrams of calcium, and that exchanges between the ECF and the cells. The cells will get it and then give it back like that. And that again goes to the kidney. 9,980 milligrams is filtered every day. out of which 100 milligrams excreted in the urine and remaining 9880 is reabsorbed back into the body. So 100 milligrams of calcium is excreted in the urine, 900 milligrams in the feces, if you 1000 milligrams. The balance is achieved provided the body has enough stores. Now, from the bone, we have something around 1 lakh milligrams in the bone. This is the fixed deposit form of the calcium, and then 500 milligrams is deposited, 500 milligrams is reabsorbed every day. See, bone, kidney, ECF, gut all play an important role in the calcium homeostasis. Calcium homeostasis, intestinal absorption, is facilitated by activated vitamin D and parathyroid hormone. Parathyroid hormone and vitamin D are essential for intestinal absorption of the food intake vitamin D. Dietary habits and supplements only in, there is usually no out from the intestine. The absorption is facilitated by active vitamin D and PTH. And of course, calcitonin, which is from the C cells of the thyroid. PTH is from the parathyroid, calcitonin from the C cells, active vitamin D manufactured in the body by photosynthesis, liver hydroxylation, kidney hydroxylation, all the steps. These three facilitate intestinal absorption. Okay, there is calcium in the blood. The intestinal absorption gets the calcium into the blood. This calcium is exchanged between the bone and the kidneys. Okay, so for the calcium to go into the bone, we require PTH, parathyroid hormone, for deposition. Again, for the bone to get the calcium, you should have calcitonin and vitamin D. So what happens? In the intestinal level, vitamin D, PTH, calcitonin facilitate calcium absorption. What is the role of this calcium? It is an important clotting factor. It is required for all the cell metabolism. Cell membrane is polarized by the calcium. The calcium depolarization is the membrane potential. So calcium is essential for membrane integrity and bone health. And the bones are subserved with the calcium by the action of, again, calcitonin, vitamin D, and PTH, the same hormones which are facilitating at the intestinal level. They also facilitate at the bone level. Now, what are the hormones which facilitate excretion of excess calcium in the kidney? Vitamin D and PTH. Vitamin D and PTH are essential for urinary output. The principal output channel is the urinary output channel from the blood calcium. Okay. Now, you have got the intestines, the ECF, the ionic calcium, the bones, the kidney. These are the areas in which they are operating. Hormones are vitamin D, PTH, calcitonin, estrogen, androgen. Women are protected from osteoporosis until they attain menopause because the estrogens are positive on the bone health. Once they get post-menopause stage, even men, when they get the andropause, when the androgen density levels will come down, then they are more prone for osteoporosis. Now, look at the right side. Small intestine, dietary calcium, fecal excretion. If you take 9,000 milligrams, 100 milligrams is absorbed, 900 milligrams is excreted. Now, what facilitates absorption? PTH, calcitrol, procalcitonin, prolactin, calcitrol, PTH, and vitamin D. They facilitate absorption into the extracellular fluid. Some calcium is secreted into the small intestine also, a small proportion. Just like the secretion into the renal tubules, it's also secreted. This extracellular fluid calcium has got two ways to go. It can go to the stores or it can get excreted. If it has to go by passive filtration into the kidney, 99% of it is reabsorbed. Whatever is filtered, only 100 milligrams is there. Parathyroid hormone facilitates urinary excretion, calcitonin prevents the urinary. So the excretion at the kidney level is guarded by PTH and calcium. PTH as well as vitamin D will facilitate urinary calcium excretion. Calcitonin prevents the urinary excretion. And now, when you come to the bone, calcitonin puts it back into the bone, and PTH and cortisol, calcitrol, these all facilitates the bone resorption. So now finally, the extracellular fluid calcium is available on the cell membrane, which generates the free calcium and then ATP for active transport. It's required, and cell membrane integrity is maintained by that. Now, what is bone? Bone is not a dead tissue. Bone is a living tissue. Many people think, bone has heart. It's not having life. It is full of life because it is producing all the hematopoietic system is from the bone, and then it's a living tissue. It is both strong and flexible. You jump suddenly the bone bends and takes the cushion. It is constantly remodeled. It is new bone is added, old bone is removed. It's called remodeling of the bone. It is made up of collagen, calcium, and phosphorus. Collagen, calcium, and phosphorus. Bone strength is determined by the collagenous proteins which give the tensile strength. The mineralized osteoid gives the compressive strength. What is tensile strength? Supposing it is there, this is there. Is there any 0? Whereas bone has got a ability to bend a bit. No, not bend means not 100 degrees. Slight, cushioning. And the tensile strength is the ability to withstand the stress and bend. And mineralized osteoid gives the compressive strength. Compressive strength means if something happens like this, it holds the structure, doesn't allow it to get compressed. When there is osteoporosis, both tensile strength is lost and compressive strength also is lost. In osteoporosis, both are affected. So, bone density is dependent on bone turnover, bone size, geometry, architecture. All four of them, bone density, bone turnover, architecture, bone size and geometry, all are factors. Bone cell lines. What are the cell lines which operate in the bone? Osteoblast, osteoclast, osteocyte. Osteoblast, the deposit the calcium, depositing DDs. These are the withdrawal checks are the osteoclast. So you go take a DD and bank deposit. That is the deposit. Okay. Withdrawal checks are the osteoclasts. Osteocytes are mechanosensors. Osteocytes, what they do, wherever there is stress and repair required, they sense and send the osteoblasts there to deposit them. And what will happen? A mason is preparing a wall. What he will do? He will take a lot of cement and then push it onto that. Osteoblasts do that. And then the mason again takes a scrape and scrapes off the excess calcium and neat, clean wall he prepares. That is osteoblast. Osteoblast deposit, osteoclast model it, and then correct the excess things it will do. And that is triggered by the osteocyte. Osteocyte senses when the blast activity is more required, when the clast activity is required more, it will trigger and then select the osteoblast and osteoclast to go and do the remodeling there. First two types conduct the remodeling, and the third type triggers osteoblast or osteoclast depending on the necessity. Trabecular and cortical bone. There are two types of bones. One is called central trabecular bone and the bone cortex. These are supporting cells. This is called the bone metabolism brew. Brew, BRU, brew, not the drinking brew. Bone remodeling unit. Bone remodeling unit. The first thing is the mesenchymal osteoblast progenerators are there. They are acted by the BMPs and then osteoblast precursors are formed. These osteoblast precursors are activated by PTH and vitamin D and other factors, and they become active osteoblasts. So these active osteoblasts, collagen, alkaline phosphatase, osteocalcin, osteoporin, bone resorption, bone cell, cellular protein. These are all the ones which are the ingredients of the osteoblast. So there are receptors called RANK-8 and RANK-L and osteoprogenin. It's called the OPG is the osteoprogenin. Hematopoietic osteoclastic progenin. Likewise for the osteoblast, for osteoclast also, we have got hematopoietic osteoclast progenitor cells. And there by MCSF and commitment, they become osteoblast precursors. And then the rank ligand makes it differentiate and produces mononuclear osteoclast. From the osteoblast only, the osteoclast. They are coming from what? Receptor activator nuclear factor kappa B, which is called the RANK. RANK means receptor activator nuclear factor kappa B, and that produces that big cell called the osteoclast, which is a quiescent osteoclast. Then interleukin 1 and RANK ligand will act on that and make it into a SAW or an active osteoclast. That active osteoclast goes and digs and removes the excess. Osteoblasts go and deposit, excess bone is removed by the clast. Clast means remove. Osteoclast. Okay. These two work in tandem. Whichever is required, that is decided by the osteocyte. This is the bone remodeling unit. Bone marrow, stromal cells are there, hematological cells are there, and there is what is called the estrogen androgen trigger is there. And finally, there is an osteoblast and osteoclast. The balance is done. And then bone remodeling unit is the combination of both osteoblast and osteoclast under the guidance of the osteocyte. Okay, coupling of the bone reabsorption and bone formation. So now you see, resting phase, that is the lining cells are there, osteocytes are taking rest, and they are there in that. Then what happened? Activation occurs, and osteoclasts are asked to come. When the osteocytes are activated, osteoclast activity is formed, then they start using their saws and remove the bone. That is the resorption of the bone occurs. And then the pro-osteoblasts are there and they form the bone and the new bone is formed. That's how the bone remodeling unit occurs. Okay. All is important. But now the peak bone mass development is completed by the age of 30 or 35. Maybe you people have another 5 to 8 years of bone strength development. After 35, you cannot increase the bones. You can only maintain the bones. So the peak bone strength is achieved by the age of 30 or 35. 85% of the bone mass is already formed by 20 years of age. What does that mean? If I take care before 20 years and eat calcium-rich food and then also have vitamin D and then calcium also, then my bone strength will be there. If I want to do it at 65 or 70, sorry, you have passed that age. You can only maintain whatever is there. It will allow you to keep what you have. You can't have a new strength. 80% of this peaking is genetic. Some people have more bone, some less bone because of the genetic. 20% of this is dependent upon adequate calcium throughout the childhood, and exercise is essential. His child, why he is 16 years by, why he should exercise? Let him watch TV, let him study, He has to exercise and diet and calcium intake are essential ingredients for bone. So you have to start exercise. How many of us are exercise? Question. We have to introspect ourselves. Bone mass declines from 40 years onwards. It goes down yearly around 1% in men above 50 years, and yearly bone loss up to 5% after menopause. 1 year, 5% of bone gone. 5 years after menopause, 25% of the bone gone. 10 years after menopause, 50% of the existing bone has. That is why we see so many fractures in the women and old. You see the peak bone mass, the child, and then the adolescent, the adult. By active growth occurs in that green phase. By then it is over, and then slow loss, rapid loss, less rapid loss, like that. Now, changes in the bone mass, you see 10 years, 20 years, 30 years in the x-axis. By around 20 to 25 years, both in men and women, the bone mass is peaking. From then on onwards, it's only one direction, going down. But look at the fracture threshold. The fracture threshold somewhere is here. Below that, the bone mass comes down, then the fracture occurs. Unfortunately, we don't allow to keep it here, and will force the bone to come down to this zone and then suffer fractures in old age. Okay. Osteoporosis definition. These are all from international references. A skeletal disorder characterized by compromised bone strength, predisposing to increased risk of fractures. Compromised bone strength includes both tensile strength and compressive strength. Compromisation of tensile strength and compressive strength is there, and this predisposes to increased fracture risk. Bone strength is equal to bone density and bone quality. Quality depends upon good protein intake and also the tensile strength. Osteoporosis. Now come OS. It is internationally called OS, not opening snap. OS is osteoporosis here. OS in cardiology is open. Here, a systemic disease results in bone loss. Underline the word osteoporosis is a systemic disease. Both qualitative loss and the quantitative loss of bone. Deterioration and microarchitecture of the bone resultant easy predisposition to fractures with little trauma or minor. Ask the patient, Amma, what happened to you? I just was sitting, suddenly I slipped and I put my hand like that. Not big trauma is required. Not a road accident is required. Simple daily activities themselves, like just leaning on the hand when you are stepping or just slipping your foot while walking can produce. Up to 20% of bone loss occurs immediately after, resultant morbidity, mortality, and quality of life. Quality is quality associated life years. Quality associated life years. It is measured. The quality of life is measured by a measure called quality associated life years. Socioeconomic burden to the society. Somebody is having hip fracture. What a burden he or she is to the family and to the society. Okay. We have no right to burden the society with bad health. We are here to protect the health of the people. You are a dispenser of health. Secondarily, you are a curer of disease. Primarily, you are a dispenser of health. We forget that. We always try prescription, injection, drip. This is secondary role. Primary role is how do I prevent disease? How do I keep the people healthy? The burden of osteoporosis. It is a major health hazard, unfortunately not recognized. 124 million Indians currently have osteoporosis or are at risk of osteoporosis. Okay. And Asian and European women are more prone. 80% of osteoporosis cases are undiagnosed or hidden. 55% of the women and 40% of the men above the age of 50 years have significant bone loss. For two reasons, because age itself reduces the bone loss. Androgens and estrogens are coming down, calcium intake is poor, exercise is zero, naturally the bones. Half of them suffer from fracture in their lifetime. Half of the elderly people suffer from fractures, at least one fracture in the lifetime. See, the magnitude of the problem. 48 million are with osteopenia. That is a condition before the osteoporosis. Low bone density, the yellow bar. Osteoporosis, 13 million with osteoporosis. Total 61 million are at risk of osteoporosis. 66% of them are women. Osteoporosis is a global burden. 323 million fractures in 1990, 1.66 million are hip fractures alone, 1.55 billion by the year 2050, 6.2 million hips alone due to osteoporosis 2050. So many orthopedicians, joint surgeons are flourishing because hip fractures are so common and nobody prevents. 5 times this number will have osteoporosis. 20% of hip patients die within 1 year. See, if a lady develops hip fracture today, 5 ladies develop, one of them will disappear by 1 year. They won't be there. 20% of them, even myocardial infarction, has no death rate of 20% by 1 year. Excluding the immediate one week, after 1 week has passed after myocardial infarction, they won't die. 20% of them don't die in the next 1 year. Whereas osteoporosis, which is the importance. 30 to 50% of them lose the functionally useful life. See, osteoporosis, relative burden. Look at the numbers, staggering, and the references are there. Osteoporotic fractures, 150 followed by 15 followed by 5 zeros. Heart attack, 5,000, 500,000, that is 150,000. Stroke, little less. Breast cancer. We give a lot of importance to stroke, heart attack, and breast cancer. Least importance we give to osteoporosis. And it is not only a morbid disease, it is a mortal disease. Somebody suffers fracture, within 1 year, 20% die. They don't know that. Osteoporosis risk factors. What are the risk factors for osteoporosis? Low calcium and vitamin D intake, low BMI, thin frame, limited exercise from childhood, smoking, alcohol, and caffeine. A cup of coffee withdraws 100 milligrams of calcium from the bone. To put that 100 milligrams back in the bone, you require 1,000 milligrams of calcium intake. Because 900 is waste. Only 100 will. Imagine. If somebody comes, immediately coffee. He's like, would you like coffee? Why don't you give them buttermilk or lemon juice or something which is more nutritious and useful? It has become such a useless bad culture that all of us, without exception, are following very bad lifestyle. Smoking, alcohol, caffeine. Genetic, female gender, four times more susceptible to osteoporosis than male gender. Asians are more prone, Europeans are also. Vitamin D receptor gene is there, procollagen is there, chromosome 11, genetic factors, chromosome 11 gene. Increasing age, postmenopausal, previous fracture, family history. What I should ask when the patient comes, what is the age of the patient? Did you attain menopause already? Did you have a fracture earlier? Did your mother or somebody in your family had a fracture? Maternal fracture, the woman had fracture 70, 80 years, her daughter has come 50 years, she has got higher risk of that. Okay, drugs like corticosteroids, phenytoin, thyroid hormones, left and right thyroid hormones are used for mild hypothyroidism. Something like TSH around 5.5. I have seen physicians putting them on thyroid. Unless it is a clinical hypothyroid, you are not supposed to treat subclinical hypothyroidism. The treatment for subclinical hypothyroidism is follow the TSH. The TSH crosses 10, then you think of it. So I know some physicians who give thyroid hormone for obesity. They think by thyroid hormone they become. Thyroid hormone is a catabolic hormone. It is not an anabolic hormone like glucocorticoids. It just reduces bone mass and muscle mass also very much. Thyroid is most abused drug. Thyroid. And patients themselves also say, sir, I am taking thyroid now. How much? 200 milligrams. Who prescribed that 200 milligrams? I start low and go slow. The treatment of thyroid disorder is start low and go slow. There is no hurry to correct the hypothyroidism. Heavens are not going to fall. But on the other hand, if you overdo it, it is dangerous. So start at 12.5 or 25 milligrams, add steps of 12.5, 12. Straight away, I have seen prescriptions. They start on 150 milligrams or 100 milligrams straight. No, not indicated at all. Okay. What are the risk factors for osteoporosis? Increasing age, female gender, decreasing bone mineral density, prior fragile fracture, family history of osteoporotic fracture, menopause, early menopause, less than 45 itself, she became menopause, and glucocorticoid, immobilization due to surgery or some other chronic diseases, thin frame, BMI less than 19, smoking, alcohol excess, calcium intake not 500, or even anorexia nervosa, propensity to fall, diabetes mellitus for more than 5 years, rheumatoid arthritis, primary increase in the parathyroid hormone, malabsorption syndromes, chronic renal failure, transplantation, hypogonadism, hyperthyroidism, L-toxin excess are all the risk factors. So how do I examine? Wall occiput distance. Other also we measured when we wanted to look at ankylosing spondylitis. Wall occiput distance. Now, osteoporosis, there will be drooping will be there. This is a marker of the PCF. Validated with thoracic and lumbar X-rays. Standing straight, heels touching the wall occiput distance of more than 3 centimeters, positive predictive value 69%, negative predictive value 79%. Wall occiput distance of more than 7 centimeters, roughly around 2.5 inches, is a predictive, highly predictive osteoporosis. The simple test asks the patient to stand near the wall. Wall occiput distance increase in for osteoporosis. Consider osteoporosis in all those above 50. Think of osteoporosis females more than 50 and more than 65. Ask for old X-ray chest and vertebral compression fractures. VCF is vertebral compression fracture. Many patients with standard back pain, elderly people, take an X-ray, there will be a compression. Undiagnosed vertebral compression fractures. So, osteoporosis, the clinical features of osteoporosis are people with unexplained back pain, spinal deformity, decreased lung capacity, impaired functional ability, loss of appetite, sleep problems, decreased activity, more bone loss, increased fracture risk, increased lung problems, and comorbidities. 23% increased mortality in those with osteoporosis. Very subtle symptoms. You ask any patient without back pain, everybody has back pain. I ask you, do you have back pain? Sir, sometimes I'm having. Not all back pains are osteoporosis. But back pain can be the presenting feature of osteoporosis. Spinal deformity. You see a gibbous, you see some spinal deformity, sleep problems. Sir, I'm not able to sleep well. You again consider osteoporosis. Okay. What are the types of this you must know. From here, for clinical knowledge, either to the background knowledge for understanding the disease. Primary osteoporosis, secondary osteoporosis. Primary means there is no known cause, like primary hypertension. Primary means there is no known cause except the age and androgens. First important thing is PMO, not Prime Minister's Office. PMO is postmenopausal osteoporosis. PMO is called the type 1 osteoporosis. When I say type 1 osteoporosis, it is postmenopausal osteoporosis. And SOS is called senile osteoporosis, also called the type 2 osteoporosis. Type 1 osteoporosis, postmenopausal, occurs only in women. Senile osteoporosis occurs in both the sexes. Type 2 osteoporosis. Secondary osteoporosis, GIO, glucocorticoid-induced osteoporosis, and other causes of secondary osteoporosis. Okay. Next one is osteoporosis and fracture also. With fracture, osteoporosis related with refractured risk, and osteopenia. Osteopenia means low bone density, not at osteoporosis. Okay. Primary osteoporosis, secondary osteoporosis, primary again postmenopausal, senile, PMO, SOS, type 1, type 2, GIO, glucocorticoid-induced osteoporosis, other causes of secondary osteoporosis. I used to have a patient 30 years back. He was a patient of rheumatoid arthritis, and we have put him on oral steroids for a short course of 10 to 15 days. because the inflammation very acute. We gave a prescription of prednisolone, 60 milligrams. I only gave. And then he continued for 20 years without coming back. Because the pain is relieved. I'm happy, sir. Doctor, you given wonderful medicine. The moment I put it, after 5 days, no pain, nothing. He was praising and telling everyone, doctor is a very good doctor. The medicine is working well. After 20 years, he came with renal failure in hospital. Right. One day he came to me with fracture. I looked at him, he became this much because steroid-induced Cushing has come and he is complete Cushingite appearance. All the full-blown features of steroid excess. And then he fracture is there. At the osteoporosis, kidney function already grade 3 dysfunction. Then I asked him, what are you doing? Sir, you gave wonderful medicine 30 years back. I'm taking that. Even not yesterday also I took, sir. Today morning also I took. Without, they just repeat the prescription without asking. That was given for 10 days and then written very clearly on the prescription. Patient must report back after the completion of treatment and I also have a rubber stamp on my prescription. Do not refill the prescription. I will put it. That stamp also is there. But the pharmacy fellows are giving. Don't refill the prescription without my knowledge. Rubber stamp I used to put. That also is there. What is the use? So to tell you that glucocorticoid-induced osteoporosis is quite very severe. So we are now going to discuss each one of them separately. PMO, postmenopausal osteoporosis, also called type 1 osteoporosis. How does it occur? Estrogen deficiency. Estrogens are very important for the osteoblastic activity. Osteoblastic receptors are sleeping because there is no estrogen. There is stimulation of the osteoclast. Osteoblasts are not there. Bone depositing fellows are not there. Bone removing fellows are activated. They go on removing them. There are two types of coolies there. One coolie goes and puts the cement. The other coolie goes and removes the cement. The ones who are going to bring the cement are not there, not working. The ones who are removing the cement are there. So cement is gone. That's how it acts. Then bone calcium leaks where? Leaks into the blood. Bone calcium leaks into the blood. There is an increase in serum calcium because of the bone leaking bones, very leaky bones. And then this excess calcium stimulates the parathyroid hormone and suppresses the parathyroid secretion. When the calcium is low, parathyroid appears. When the calcium is high, parathyroid is suppressed. Parathyroid is suppressed. Parathyroid is required for the 125 hydroxylation of the vitamin D. That is not taking place. And the parathyroid hormone is the fellow who helps the signature of the kidney 125 hydroxylation. That is not happening. So kidney is not doing vitamin D conversion properly. And then if kidney is not working properly, vitamin D is not properly formed, active metabolite, intestinal calcium absorption is decreased. And negative calcium balance occurs. Osteoporosis. See? One simple factor, estrogen deficiency, increases the osteoclastic activity, decreases the osteoblastic activity, bones start leaking their calcium into the blood. This leaked calcium elevates the serum calcium, elevated serum calcium suppresses the parathyroid. Without the parathyroid, 125 hydroxylation cannot occur. Vitamin D active metabolite is not there. Without vitamin D, calcium cannot be absorbed. So calcium deficiency occurs, negative calcium. Now, how do I treat? The treatment is in the slide itself. Supplement the estrogens. Okay. Supplement the vitamin D active form. And then give calcium orally. Oral calcium, oral this one. And then parathyroid hormone also could be a treatment because there is no parathyroid. Extraneous parathyroid I can give outside. Okay. Calcitonin also I can. Postmenopausal osteoporosis. Supplemental estrogens. Supplemental parathyroid, supplemental vitamin D, supplemental calcium, and then working. Senile osteoporosis, also called the SOS or type 2 osteoporosis. The mechanism is slightly different. Here, 125 dihydroxy cholecalciferol formation in the kidney is at fault. So 125 dihydroxycholecalciferol is not formed. That leads to intestinal calcium absorption decreased. When there is intestinal calcium absorption is decreased, parathyroid hormone because of hypocalcemia, parathyroid is stimulated, excess parathyroid occurs. The parathyroid goes to the bone and then brings the calcium because there is no calcium in the serum. It thinks it can go to the bank and bring it. and then withdraws the calcium from the fixed deposit and then tries to elevate. That leads to bone resorption. That leads to negative calcium. Here the treatment is correct the renal issue and give supplemental, vitamin D and then supplemental calcium also. So much so the parathyroid is kept under control and excess bone resorption is stopped. Now, glucocorticoid induced, this is my patient story, induced GIO, common iatrogenic, that is doctor has given the prescription, that's why it is called iatrogenic. So if I had not treated him with that 10 days with that prednisolone, probably he would have survived another 10 years without renal failure, but with rheumatoid arthritis being very severe. Okay, 3 to 6 months continuous use needed to cause that. That today you take one prednisolone, tomorrow nothing will happen. At least 3 to 6 months long-term steroid use is always dead. Inhaled steroids in general are safe, but in high doses may be harm. Oral steroid use for chronic asthma, skin conditions like psoriasis and other eczematous conditions, COPD, rheumatoid arthritis, inflammatory bowel disease are common causes of steroid overuse. 50% of patients suffer osteoporosis-related fracture. Must consider doing a bone mineral density. Consider drug therapy with bisphosphonate. How do I do that? I treat these fellows, stop the steroid now, and then give them bone mineralizing drugs like bisphosphonate. What is the pathophysiology? How does GI work? I have shown you how senile osteoporosis track and also the PMO, how does it happen? Now I am looking at GIO pathophysiology. The glucocorticoids are there. These glucocorticoids, they act in two ways. One, they decrease the GI absorption of calcium, increase the urinary calcium, and decrease the serum calcium. With the result, they stimulate the serum calcium, which is low, parathyroid hormone. Stimulated parathyroid hormone is a bone resorbing hormone. Osteoclastic activity occurs here, and then through the osteocytic apoptosis also. Osteocytes are apoptosed because of glucocorticoids. Osteocytes are essential for osteoblastic activity. So osteoblastic activity is reduced. That results in osteoporosis. And glucocorticoids, they suppress the adrenal androgens. They suppress the testosterone. They suppress the estrogens also. With the result, osteoclastic bone resorption and osteoporosis. Multiple mechanisms. Steroids act. Okay. Primary osteoporosis, two types. Senile osteoporosis, then postmenopausal. Secondary osteoporosis, mostly glucocorticoid induced or other causes. What are the other causes? How do I identify secondary causes of osteoporosis? CBC, ESR, X-rays for fracture, little use for osteoporosis, but you know the result. Yeah? IPTH, intact PTH. Intact PTH means how do you take the sample? You say take the sample in the morning, the fasting state, to draw the venous sample, cubital vein, and put it in a container, ice it, put it in the ice, dip it in the ice. All around it will be 5 degrees, not more than. Then only the parathyroid hormone will not deteriorate. Otherwise, if you put it in the room temperature here and send it to the lab at 12 o'clock, they analyze the next morning, PTH will be 0. And they report no PTH. And then you think there is hypothyroid. Wrong. So if you're not properly sending the sample, you get a wrong. Okay. IPTH, called IPTH. IPTH, if you write, the lab, the moment the sample comes, they will try to analyze it. Calcium, phosphorus, vitamin D. What are the things? CBC, ESR, X-rays, IPTH, calcium, phosphorus, vitamin D levels. For kidney, look at the creatinine. For the liver, look at the AKP, GOT, GPT, and albumin. For thyroid, do the TSH in the fasting state, testosterone, men, estradiol, follicular stimulating hormone, and androgens in the women. That is adrenal androgens. Urinary calcium, urinary free cortisol should be seen. Protein electrophoresis for multiple myeloma. Bence-Jones proteins, you would have heard. That is, what is Bence-Jones protein? How do you detect that in the urine? Supposing the patient has got albuminuria, I hate the urine, what will happen? Precipitate, isn't it? That is called heat test, protein precipitation test. Depends on protein. When heating, protein appears. After some more heat, it disappears. Because they are not albumin or other things, they are gamma So they disappear after overheat. Then they appear and disappear. It depends on. Okay? Simple things you must learn. So, osteoporotic fractures, which is the most common site of osteoporotic fracture? Hip joint, vertebral compression fracture, thoracic and lumbar, Colles fracture, and distal radius are the three important. That is why when you have to do bone mineral density, you ask them to scan the hip, scan the vertebrae, scan the wrist. This is called triple DEXA scan. DEXA is dual absorption X-ray radiometry. DEXA scan, DEXA, dual absorption X-ray radiometry, done for three sides. One side is both the hip joint, vertebrae, thoracic and lumbar, and the distal radii of both. Okay? Proximal humerus, proximal tibia, pelvic bone, ankle malleolus, the other sides of osteoporosis. Commonly, osteoporotic fractures means hip fractures, vertebral compression fractures, Colles fracture, and then the Denner fork deformity, like that. And distal radii. Okay? Now, proportion with vertebral deformity. You see, age group, vertebral deformity, both men and women are same as far as vertebral deformity. At 50 to 59 years, less than 20% have vertebral deformity. 60 to 69, women have more vertebral deformity. 70 to 79 also there, more vertebral deformity. And by the age of 80 to 86, 60% of the women and men have vertebral deformity. See, the old people, it's because of the vertebral deformity. So that's why the wall also. If you ask them to stand like this, they cannot stand like an animal. That is because of the vertebral. The wall oxport distance should be 0 or maximum 3 centimeters. It is more than 3, say more than 7 also, because of the fracture, compression fracture. You take a Coca-Cola, can Coca-Cola, you will be drinking, take the can, push with your foot, lap, like that the vertebral body compresses, the anterior part will be compressed and it will be like a wedge compression will be. So very few adults around 70, 80 years can stand it because they do the exercise. Exercise is the main ingredient, not at 60 years. 60 years you have to do exercise, but you should start much before your age. Okay? Vertebral deformities are so common. Osteoporotic related fractures, hip fractures, spine fractures, wrist fractures. Commonest hip, next spine, next wrist. All together that much. Clinically diagnosed fracture. There will be so many clinically undiagnosed fractures. Okay? Now you see. Osteoporosis related hip fractures more than the combined lifetime risk of breast, uterine, ovarian cancers put together. Lifetime risk of breast cancer, ovarian cancer, uterine cancers you combine and put in one mass. This is hip fractures are much more than that. Underline, people do not realize the importance. If fracture comes, they treat it, put some nailing, all that repair rod and all they put, recover, but they don't evaluate for osteoporosis. So what are the outcomes? What will happen if somebody gets hip fracture? These are all from international studies. 50% will have loss of function. Is it good? A person, 60-year lady, not able to do her toilet also. What is the use of her living? What is the quality of life she? And 20% of them disappear in 1 year. They won't be there. And the Aadhaar card will be cut off. No PAN card. No Aadhaar card. Nothing. 20%. Full recovery is possible with good care only in 30%. The 1 year outcomes are drastically frightening when you look at the 1 year outcomes, hip fractures. Okay. Now, now you see osteoporotic hip fractures, 250,000 hip fractures every year, 25% excess mortality, 65,000 Indians die every year of hip fracture, 50% permanently disabled, 20% require long-term care from the society, wheelchair, walker. You keep on seeing these people. I can walk. I want a walker. First 2 legs. After that, one more leg, third leg, then 4 legs. And that also not so. Because you are taken care when you are young. You are smoking, you are drinking, you are consuming coffee left and right, not taking vitamin D, not taking calcium, not eating milk and meat and other products. Naturally, you suffer. Osteoporotic fracture, bed days, breast cancer bed days are into 1,000. That is, in women aged 45 plus years, 40 days of in bed breast cancer, myocardial infarction 35 days, COPD 30 days, diabetes 22 days, hip fracture 45 days in bed in 365 days. Is it okay? 50%. And that means around 1/3 of the beds are occupied with the hip fracture fellows. And they don't go away immediately. Myocardial infarction fellow get discharged on the 4th day. Whereas hip fracture fellow will be there for 3 weeks, 2 weeks. Bed occupancy. Fractures with aging. You see the red one is the forearm fracture risk and the yellow one is the spine and hip is the blue. So as you age, after 60, 70, the risk of forearm, spine and hip fractures is so great. Colles, vertebrae and hip. You see the vertebral fractures, they increase with age like anything, and then Colles fractures more or less stable, and then hip fractures. So they all have international references there. Now look at the bone the God has given. Mother has one year. Mother gave birth to you. She has given a bone as dense as that. But we spoiled it and made it as useless as that. It is total demineralized bone compared to beautiful normal bone with trabecular. Now you see, this is the cancellous bone, and say that is trabecular bone. You see how dense it is in the initial stages, and bone quality is not the only factor. Normal osteoporotic. The osteoporotic bone is like a seed. Any moment, right. Just slip, right. Treatment is also very, see that bone. Severe osteoporosis of the femur. Is there any bone at all? As though some cancer has eaten away. As though there is a secondary bone tumor which is eating away, that such is the status of the bone. Treatment part has come to our next class. But at least let me finish the clinical part. Okay. Yeah, you see the height of the individual. So originally like that, bent. At least 3 to 5 centimeters of loss of height. 165 when I am young, 160. That will be the story, not me in general. I'm 73. Means what? Exercise, diet, proper health keep. By every day, 5 kilometers in the morning, 5 kilometers in the evening, walk 10 kilometers of walk for the last 30 years. Right from the age when I was 35, 40. And now last 2 years, 1 hour gym in the morning with the assistance of a physiotherapy trainer, exercise therapy trainer. Comes and does every day, 1 hour. So 3 hours gone. 2 hours walking, 1 hour gym. Remaining time only I am using. Eat nothing, no carbohydrate. Only protein, vegetables, fruits, nuts. No coffee. No sugar for the last 35 years. I stopped sugar and oil for the last 35 years. 35 years. What motivated me? My father was a severe diabetic. We lost him when he was 58 years old. At that time, I was 25 or something. Then this will catch me. He is a severe diabetic. He died at 58. I should not be a scapegoat for that diabetes. My family, there are 5 people, my siblings. All 4 are diabetics, excepting one person. Genetics load the gun. Environment pulls the trigger. A loaded gun is more danger unless you pull the trigger. Pulling the trigger is in your hand. You may be genetically very weak in terms of diabetes and osteoporosis. But then if you take proper care of yourself, you can avoid the onslaught and the phenotypic expression of the genes. Genotype is one and phenotype is. We should be a role model for others and also for ourselves. Isn't it? Fitness, activity. Want to teach at 73. Why I can as well watch cricket match today. Beautiful cricket match may be coming. Some India, this Bangladesh. Somebody is quarreling with one another. Way in which you carve your life. It's very essential. Look at that wonderful lady in 40 years, how erect and nice, smiling. That same lady at 75 years, how she. All of us will be like that. The time is waiting for us to transform our bodies like that. No doubt about it. But then you'll look ever young. You don't require to think that you are old at all. You see, wonderful lady. Then they started having one stick, then having support of the 4 legs plus 2 legs, 6 legs. Then finally, these are vertebral fracture and physiological change. Osteoporosis secondary. Now we require to know what are the secondary osteoporosis. As I told you, hyperthyroid, either iatrogenic hyperthyroidism or original hyperthyroidism, primary hyperparathyroidism, estrogens, testosterone deficiency, Cushing's disease, like my glucocorticoid fellow, hyperprolactinemia. I have a beautiful case. She lives in Marathali. Hyperprolactinemia. She is around 35-year-old lady. Hypercalcium. Renal causes, renal osteodystrophy. Von Reckling-Hossen's disease. Renal osteodystrophy. That is the kidney failure. Kidney is not able to handle vitamin D properly. Kidney is throwing away the calcium, wasting the calcium, just like the son and daughter waste the father's money. The kidney is wasting the calcium. And it is not conserving the calcium. Vitamin D is also not there. Produces secondary hypocalcemia and bone thinning, bone break. Cystic bone disease. Ankylosing spondylitis, the other day we have seen, rheumatoid arthritis, gastrectomy, celiac disease and malabsorption, hepatic primary biliary and idiopathic biliary cirrhosis, multiple myeloma, Gaucher's disease, leukemias, mastocytosis, infiltrative, connective tissue disorders like osteogenesis imperfecta, homocystinuria, Ehlers-Danlos syndrome, Marfan syndrome. These are some rare congenital disorders. Nevertheless, all these account for 10% of the osteoporosis. 90% of the osteoporosis is primary osteoporosis. Senile and postmenopausal, maximum glucocorticoid. All others are for completion. And thyroid you keep in. Okay. Risk of recurrent vertebral compression fracture. Okay. 20% will have a new vertebral fracture in 1 year. If you had a vertebral fracture this year, 20% of them die, 20% will have another fracture. See, the story overall, number of percent of patients, 20%. There, 0 fracture, 1 fracture, 2 fracture. If you had 0 fracture, that is, and one fracture and had 2 fractures, naturally the risk goes on doubling there. Now, see that, the wedging there, beautiful wedging. See the wedge shaped vertebra. No, this is not right. See that vertebra there? Like a wedge, with lesser height in the front, the height normal back. That is the bump. So look for spinal deformities. And then wall occiput distance, what will be this for this lady? Maybe 10 centimeters or even more. Because 1 foot from the wall. Her head. 7,750 spine fractures every year. Two-thirds are clinically silent. The only symptom they have is back pain. Many a time back pain is ignored. And there's no back pain. Old lady, you have some back pain, don't worry. As though they take it for granted and then they don't take action. Acute or chronic back pain, decrease in the height up to 6 centimeters, respiratory and GI difficulties, daily life activities are compromised. This leads to loss of self-esteem and depression and increase in all-cause mortality. All are due to osteoporosis spine fractures. Okay. We will stop here and then we'll see the remaining story next time. Most importantly, the modern management of osteoporosis is very important, and I will tell you